Okay, anything we need to add to our laundry list? So, respiratory or cardiac things that are still confusing. Oh, I forgot to let you guys talk to me. Okay, now you can talk to me. Okay, so anything from our laundry list. Okay. So we will start with our respiratory. So when we think about our respiratory anatomy, there are some pretty big differences between adult respiratory system and our pediatric respiratory system. So if we start from the very beginning, our newborns are obligate nose breathers. So they prefer to breathe through their nose. They also have smaller airways and those higher respiratory rates. They tend to breathe through their diaphragm. So we also can see some brief periods of apnea with them. They forget to breathe. So we'll see them with those prolonged periods where they're kind of holding their breath. As they grow, their respiratory rates will start to slow to that normal. Their breathing becomes more involving their entire thoracic cavity. We know their lung volumes and capacities increase as they grow. Um, our lungs are still developing until we're two, still growing for those first 2 years of life. Our pediatric patients have a highly compliant chest wall, so it's really, really flexible. That allows for greater fluctuations in that pressure inside their chest cavity while they're breathing. We also know that our kids have a shorter trachea. Their ribs tend to be more horizontal, and they have uh, increased risk for airway obstruction and fatigue if they have respiratory distress, just because of those anatomical changes. As they grow, their respiratory pattern, like I said, transitions to more of that thoracic breathing by the time they hit 7. So all of those changes are going to affect our um, overall respiratory system and our respiratory assessment. So, how do those differences in our pediatric respiratory system affect our overall assessment? What are some differences that we might notice or changes to our approach we might have to take? What do you guys think? You guys can type them in if you don't feel like talking to me. I'll drop our Menti link in the chat again. There we go. So, how can those changes in the pediatric respiratory system affect our assessment of them? What are some things that we see with them that tell us that they're having difficulty breathing?
Nasal flaring.
Mm-hmm. Nasal flaring, for sure. What other signs of respiratory distress do we remember? Stridor.
The
A
signals
retraction, the
that
chest retraction.
That they use their stomach to breathe.
Mm-hmm. Yeah, so we see those accessory muscles being used. They can use their stomach muscles, their neck muscles, their head. We can see that head bobbing sometimes. Katie, I saw you said something. What did I hear from you?
No, the thing is that the pediatric respiratory system have smaller airways. Then, when they have, for example, croup, it's difficult to breathe in, and then you have to use the muscles to breathe in and have a shortness of breath, wheezing, and it's hard for them.
Yes. Yep, those really tiny airways obstruct very easily. So even just a minor illness like a cold can really cause a lot of respiratory distress. We see those retractions where we see them sucking in every time they're taking a breath. We can see those all throughout their chest cavity. Uh, because they have those really compliant chest walls and those small airways, do you think it's easier or harder for sounds to transmit through the chest?
Repeat again.
Because they have those small airways and that increased chest compliance, do you think it's easier or harder for those sounds that we're listening for to be transmitted across the chest?
No, it's harder.
It's actually easier. So, because they're so tiny, we can hear those sounds outside of where we normally would expect them. So, if I have a lot of upper airway congestion, normally in an adult, it would be confined to like my trachea. But because I'm so tiny as a pediatric patient, I can hear it in the upper lobes. I might even be able to hear it in the middle lobes when I'm listening. So those sounds get dispersed through the entire chest cavity. So sometimes it's hard to pinpoint exactly where that issue is in our pediatric patients. What else tells us that they have respiratory distress? If we're just looking at them.
How their
Sometimes they
chests
may be
rise and
restless.
fall.
I heard restless. What did you say, Whitney?
How their chest rise and falls.
Mm-hmm. Yep, we can see that chest rise and fall. Their color changes. Remember, they can get pale, they can turn blue.
Mhm.
Also, they can be confused sometimes. So, confusion is a sign of respiratory distress that we often don't think of. Uh, and then, how do we help to make them feel better so that they can breathe easier? What do we do to them?
Treatment, treatment,
What was that, Emily?
a treatment treatment.
We can do
What
breathing
the
treatment.
way
Yep.
depends on what they have.
Yeah.
Antibiotics sometimes.
Mm-hmm. Yep. What's something really simple that we can do that helps you breathe easier when you're struggling to get in a big breath?
Maybe sit up,
Yeah,
change
proper
position.
positioning.
Mhm.
Yep. So you'll see a lot of times with especially our pediatric respiratory disorders, they want to sit in a tripod position. They want to be forward, propped up on their elbows so that they can really expand that chest and have an easier time breathing. So, which of these findings is going to be characteristic of RSV in infants? So, super common respiratory disorder in infants. Thankfully, now we have some new medications that we can use for our infants to help them during RSV season. We used to only treat our high risk infants like our NICU babies or our cardiac babies. But recently, as in the last couple years, we've been able to open that up to more kids. So our nasal flaring and retractions are going to be very common with RSV. We see that increased work of breathing um, caused by that virus. Okay, so we're going to take a peek at this patient and tell me what you suspect our condition is. We're going to talk about signs and symptoms that we saw and what we can do for treatment. So, our first note, we received a call on our triage line. Mom reports her infant is working to breathe but appears stable, maybe has a fever. Mom's asked to count the breathing rate and says baby's breathing 50 breaths a minute. No nasal flaring or belly breathing. The triage nurse told them to undress the baby, turn the shower on full hot water, close the bathroom door, and take that infant into the bathroom right away. Don't give them anything to eat or any medicine, and then call back in 10 minutes and see what our response is. So mom does all of those things. She calls back. She said the coughing is better, but baby is still working to breathe, irritable and hot. So the triage nurse now tells her to call 24-hour urgent care and go immediately in their personal car. So mom unfortunately panics and calls 911 instead. So EMS shows up. We have a 10-month-old infant in respiratory distress, moderate distress noted. Heart rate is 164, respiratory are 42, blood pressure is 100 over 70. Our oxygen saturations are 94%. We have a barky cough with good lung aeration. We put the baby on a nasal cannula to give some blow, but the baby is pulling the cannula off. So we give blow by oxygen at 50%. And now we are en route to the ER for evaluation. So what condition do you think we have here based on that assessment? And all of those signs and symptoms. Maybe let's start with our signs and symptoms that we're seeing. What are we seeing with this baby?
Coughing.
Yep, we have a barking cough. That's our telltale sign right there. Little bit of tachypnea, maybe some, we definitely have increased work of breathing, maybe a fever. So with those things,
Oh,
what was that, Shamika?
the O2 sat is below 95. So
Yeah.
it's like 4.
Yep. Based on all those symptoms that we're seeing, what condition? Which one has that barking cough? Respiratory disorders. Croup. Yes, good job. This is croup, classic croup. Why do we tell mom to put the baby in the bathroom with the shower running? That seems like a weird intervention.
The heat.
Yeah, we're trying to increase that humidity to help loosen those secretions, help alleviate some of that obstruction there. Ideally, we want cool mist because it helps to soothe those inflamed airways, helps relieve that breathing difficulty. Once we get to the hospital, what are some other treatments that we can do to help with croup? There's 2 different types of medications that we can use.
Corticosteroids.
Yes, corticosteroids, dexamethasone, prednisolone. Those are both going to reduce airway inflammation, improve that breathing. So typically we will give those orally. If we have to, we can give them IM. What's the other thing that we can give? to quickly relieve that airway obstruction?
Epinephrine.
Yes, the racemic epinephrine is a nebulizer treatment that's used for those severe croup cases. It provides that temporary relief of that airway obstruction. It's going to open up those airways really, really quickly for us. Obviously, if our child is hypoxic, we're going to give them supplemental oxygen. And there is possibility that we might have to intubate depending on how severe our respiratory distress is and how bad that obstruction is. Anytime we have a respiratory illness, we want to make sure that we're keeping them nice and hydrated, and then also keeping that fever under control. So if we have a child that's exposed to smoke inhalation, what complication are they at risk for? What happens to our airways when we inhale smoke?
I think inflammation.
It's going to cause that airway inflammation, increase our respiratory distress, can cause bronchospasms. So as those airways get irritated, they kind of quiver and spasm with that smoke. Okay, what instructions do we need to include after a tonsillectomy? So thinking about that discharge teaching for tonsillectomy. So we want to avoid strenuous activity for 2 weeks so we're not putting stress on that incision causing bleeding. Why do we avoid aspirin in our pediatric patients? Why don't we give aspirin to pediatric patients?
Because the Ray's disease,
Yes, Rye syndrome. Yes.
Ray's syndrome, sorry, Ray's syndrome.
Yep, I knew what you were going after. Yes, so high risk of Rye syndrome anytime we give aspirin with flu-like illnesses. So we tend to avoid it altogether in pediatric patients. Okay, we're gonna save our CJ Sims for the end. There's some good stuff there, but I want to make sure we get to our cardiac patients. Here we've got one more patient in respiratory distress. So our patient is 7 years old. We have a fever. We have acute respiratory distress. We are agitated and restless. We are showing signs of air hunger. Dad lays the child supine on the stretcher and the distress gets worse. So they sit up and assume a position of comfort, tripoding on those hands and knees, or tripoding with their hands on their knees. We see accessory muscle use. Our lips are cyanotic. We've got lots of retractions, nasal flaring, and we are drooling, breathing with our mouth wide open. What condition do you think this is? Severe respiratory distress with drooling. We insist on sitting up, leaning forward with our mouth wide open. Which respiratory condition is that?
I can, like, the airway is obstructed, maybe. or
Yep. So this is classic epiglottitis. So we've got swelling above our vocal cords. So we see that respiratory distress, we're tripoding, we're drooling with our mouth wide open. We can't swallow anything or cough. So we are really, really struggling here. So we bring anesthesia to the bedside so we can intubate this patient. We give them some rapid sequence intubation medications so that they are cooperative. We don't cause any additional airway trauma. And then we are able to suction and develop good respirations and alleviate some of that respiratory distress. So priority nursing interventions for this patient is going to be an advanced airway before we do anything for them. We can't put anything in their mouth. Like I said, they can't swallow, they can't cough. They are at high risk for further obstruction if we agitate them. So we want to make sure that we keep them nice and comfortable. We are going to sedate them before we intubate them. Okay. What is an effective way for us to reduce the risk of sudden infant death syndrome? What are those ABCs that we remember? So the best way to prevent SIDS is teaching them about safe sleep. So those are the ABCs of safe sleep: alone, on their back, in a crib. We want to make sure they don't have anything loose in that bed that they could roll over and obstruct their airway, maybe not be able to get away from. We don't want blankets to be covering their faces. Pacifiers actually can help prevent SIDS. So that is something that we should encourage. We know our infants need to work on those oral skills. Okay. And then moving on to our cardiac patients. What do we include in our care plan for all of our patients with a cardiac condition? So all of these are going to be part of our plan of care. Every pediatric patient, we have to consider their growth and development. Every patient, we think about supportive care for them. Looking at those vital signs, oxygenation, we know that our respiratory and cardiac systems are very closely linked. And then preparing for surgery if we need a surgical correction there. Okay, let's look through some of these cardiac disorders. So the first thing on all of these, you will see a normal picture on the left-hand side, and then you'll see our defect on the right-hand side so that we can compare and contrast and look at the differences here. So the first two disorders that we're going to look at are septal defects. So a septum is just a wall. So we can see that we have this nice wall that goes in between the two chambers of our heart here. These are valves that go in between the atria and the ventricles. But if we have a hole anywhere along this wall, we have a septal defect. And our location, conveniently, is the very first word in our disorder. So an atrial septal defect, we're talking about a hole between the upper two chambers of our heart. So it allows our oxygenated blood to flow backwards into the right atrium. We're going to monitor this patient for heart failure, arrhythmias, and growth delays. We will eventually close this with either surgery or a catheter closure if the baby is really struggling to grow and maintain their oxygenation. So like I said, there's two of these, and you will need to be able to keep them straight. So the way that I remember this is A points up. So it's talking about the upper chambers of the heart. And as you can suspect, our next defect is a ventricular septal defect. So it's the exact same thing, except the hole is between the lower chambers of our heart. So our V points down, meaning our lower chambers are the ones affected. So again, we have oxygenated blood going from the left side of our heart to the right side of our heart. And we are, again, looking for heart failure, monitoring that growth. If that defect is particularly large, then we will surgically correct this. Next, we have a patent ductus arteriosus. So we have an opening between our aorta and our pulmonary artery after birth. So this is this extra vessel. So normally these are two distinct structures, not connected in any way, shape, or form. But here in the PDA, you see we have this extra little vessel that connects our pulmonary artery and our aorta together. And normally that vessel closes right after birth. So we need it to function in utero, but it should close on its own after birth. This is one of the few defects that we can correct with medication. So for the purpose of your HESI, they want you to remember the medication indomethacin. So indomethacin is what they are going to try to use as the least invasive way to close a PDA. You will see in practice that we use either Tylenol or ibuprofen because indomethacin can cause necrotizing enterocolitis, and we don't like to see that in our premature babies. But for the purpose of the HESI, remember indomethacin closes your PDA. If that doesn't respond to medication, then we can either insert a little plug in this vessel to block it off, do that less invasive catheter closure, or we can actually surgically tie this off. Just put a big suture here and close that extra vessel. Next is going to be our coarctation of our aorta. So normally our aorta is nice and wide, lots of blood flow going through there. But in this picture, you can see we've got a kink in our garden hose here, and they blew it up even bigger for us so that we could see in more detail. So we've got all this blood rushing at it, and because that garden hose is kinked, only a teeny bit of blood makes it through there. So the easiest way to identify this in a patient is comparing your upper extremity blood pressures to your lower extremity blood pressures. So you're going to see increased blood pressures in your upper extremities and decreased in your lower because your blood's not able to get through there. Tetralogy of the below is our hardest defect to understand because it is a combination of 4 defects in one. So we have pulmonary stenosis, we have a ventricular septal defect, our right ventricle is hypertrophied, and then we have an overriding aorta. So if we look at our normal blood flow, normally we come in through the right atrium, we slide down into the right ventricle, go through our pulmonary valve, into our pulmonary artery to our lungs. Then we come back through the veins, pulmonary veins, oxygenated into the left atrium, down to the left ventricle, and out to our body through the aorta. With tetralogy, we start out great. We come in through our right atrium, we go down to our right ventricle. We have pulmonary valve stenosis. So this pulmonary valve here is really, really thick, which makes it really hard for blood to go through there to get to our lungs to be oxygenated. We also have this ventricular septal defect, and it's nice and big. So it's really easy for my blood to go from my right ventricle into my left ventricle, skipping my lungs altogether. So deoxygenated blood getting into my left ventricle and eventually going out my aorta. We also have a really strong right ventricle. So this right ventricle is enlarged, giving you that boot shape appearance on X-ray. And so that muscle is huge and really beefy, and it makes it even easier for that blood to go across to the left ventricle. So we've got a lot of unoxygenated blood going out to our body, which causes us to have sudden drops in our oxygen in our body. So suddenly we will be cyanotic and blue when we're being really active, and those are called TET spells. The one thing that you have to remember with the TET spell is you've got to get those knees up to the chest to make it go away. So for an infant, you're going to need to pull their knees up to their chest to kind of reverse all of that shunting and help them to be able to utilize that oxygen. For an older child, you will see them running on the playground, carrying on, having a great old time, and they will stop dead in their tracks and they will squat themselves. So if you see that in a pediatric patient, they probably have tetralogy and they are experiencing a TET spell, and they are trying to correct that condition and get more oxygen flowing to the rest of their body. Okay, another disorder. We're moved kind of past the anatomical defects. Now we're talking about other cardiac disorders here. So we've got a child with rheumatic fever after a recent strep infection. Which medication do we suspect we're going to have to administer? So what medication do we give to those patients with rheumatic fever? So for rheumatic fever, we actually give penicillin, and that's going to help prevent any further damage to the mitral valve as a result of that rheumatic fever. So they are going to be on penicillin to treat that initial infection, and then we're going to continue that penicillin for 5 whole years to make sure that that strep throat infection doesn't come back and cause that mitral valve damage. So any patient with rheumatic fever will be on penicillin for 5 whole years. We have a 12-year-old that comes in for hypertension, so high blood pressure. Which finding is most suggestive of secondary hypertension? So primary hypertension is the same thing as essential hypertension. Got high blood pressure that develops gradually over time without any particular cause. So it's going to be the most common type of hypertension that we see. Secondary hypertension is going to be caused by an underlying medical condition or a medication. So for primary, we don't have a specific cause. We're looking at those general risk factors: genetics, obesity, sedentary lifestyle, poor diet, advanced age. For secondary hypertension, because we've got either that underlying medical condition or it's caused by a medication, we're looking at things like kidney disease, endocrine disorders like Cushing's syndrome or hyperthyroidism. We might have a cardiac defect like a coarctation, sleep apnea, medications like contraceptives, NSAIDs, corticosteroids can all cause hypertension. Those are all examples of that secondary hypertension. And then we have a client with a fever, conjunctivitis, a rash, swollen hands and feet. What diagnosis do we suspect here? This is Kawasaki's disease. So with Kawasaki's disease, we don't have any definitive like diagnostic testing that we can do to say, yes, this is what you have. It is strictly based on symptoms. So typically these patients will come into the ER because they've had some sort of viral illness for the last week or so, really high fever, and they're just not getting any better. When they come into the ER, we see that they have conjunctivitis or looks like they have pink eye. They have rashes on their body, swollen hands and feet, cracked skin, really dry lips. That is classic Kawasaki's disease. Okay, guys, that is the end of our Minty here. I do want to touch base on, okay, asthma very quickly. We're not going to have time to talk about Katrina today. But with asthma, we do need to remember that this is the leading cause of missed school, ER visits, and hospitalizations for our pediatric patients. So asthma causes them to be in the hospital, miss a lot of school, very common for them with those exacerbations that we see. With Ainsley, we are going to take a peek at her chart really quickly. So she was diagnosed with cystic fibrosis at age 2. She's been sporadic with taking her medications for about 3 months and stopped her meds and chest physiotherapy in the last week. Now she's coming in with decreased breath sounds and rule out pneumonia. So that is why we have her in the hospital. And you can see that we saw her recently a couple months ago and she was 88 pounds. Now, when we admit her, she is 78 pounds. So why do you think we saw such a big weight drop with her, knowing that she has cystic fibrosis? What do we know about the nutrition status or the changes to our nutrition with cystic fibrosis? Is it easier or harder for us to digest our food and actually pull out the nutrition?
Harder.
Yeah, these kids have a really, really hard time with pulling out the nutrition. So they actually need 150% of normal caloric intake just to survive. So they need high protein meals. They have a hard time digesting fat. So they rely on proteins, carbohydrates to fill in those gaps. They also struggle with vitamins A, D, E, and K because typically those are fat soluble vitamins. So we have to give those in a water soluble format. We are also doing a behavioral health contract with her because she stopped taking her medications. We are sending her home with home health. so that we can increase her compliance. So that is one of the common problems with these patients is they are on a ton of medications and a ton of therapies, and they often don't like to be compliant when they reach those teenage years. So we see a worsening of their condition because of it. So one of the things that we can do is we can send them with telehealth or home health care to help increase that compliance. So I do apologize that we didn't have a lot of time for our CJ Sims today, but at least we got through the meat and potatoes of our content. You guys have your first CJ Sim that is due today. So not due today, due this week. Thank you to Brittany for telling me that it wasn't unlocked for you guys. You guys had the wrong patient unlocked this week. So it is fixed now. You should be able to do RECE without any problems and be able to get that submitted. Next week, you have our second CJ Sim, which is Mario Stevens, and our discussion 5 post. We will have quiz number 4 next week that's going to go over cardiac and respiratory. So that study guide for week 6 will be helpful for you. If you did not notice, our homework grades were turned on this week. So if you saw your grade shift, that's because homework grades are on. If you have not done homework this term and you see that reflected in your grade, know that you can still submit your week 5 NCLEX questions if you have not yet. And then make sure you get these 2 CJ Sims in on time. That will be really, really helpful for you.